everybody, and welcome back to the Bodcast. Today's episode is one that I've been really excited about for about a year now. As soon as I got pregnant, like many women, I was really worried and intimidated by what the changes to my body would mean and what they would look like. Not only to my mental relationship with my body and my body image, but also from an aesthetic and a performance standpoint as well. Diastasis recti, pelvic floor health, the C-section pouch, scarring, wrinkly skin, all of it started to come to the fore as I entered my second and third trimesters and watched my body ever changing. Don't get me wrong, I'm going to be really upfront here and admit that I'm one of those women who can confidently say that she loved her pregnant body, but it was the ramifications thereafter that I was extremely nervous about. So in my third trimester, I thought, why am I waiting for a mummy MOT? I want to take the bull by the horns and go now. So when I sheepishly explained this over the phone to my soon-to-be women's health physio, Jo Gipson, I was met with a very assured and supportive, of course it's better if we start now, when can you come in? So on today's podcast, I cannot tell you how excited I am to inform and educate not only pre- and postnatal listeners, but all women listening who might be suffering with any kind of incontinence issues, potential prolapse issues, sexual pain, and all the other things that only us wonderful women can relate to. We will actually touch on some male issues as well, though. I do actually hope there's some men listening, whether you PT or coach or you just like the podcast, because I think this is going to be maybe one of the most informative ones you've ever done. So after the world's longest intro, I'd like to intro my amazing women's health physiotherapist, Jo Gipson.
Hiya, thank you for having me. What an intro.
Like 20 minutes later.
I know, thank you very much. I feel honoured.
I wanted to just give some context though, because you are a specialist, you're extremely well informed. You have a hell of a lot of experience. You come highly recommended. You're brilliant. But also, I kind of want to bridge the gap between people listening to understand that, like, even though I work in the body, I too had all these worries, and I too had my own physical issues as well, and that it's really, really normal. I think let's just dive right in. And the obvious first question is, can you just tell me a bit about yourself, what you do, and how you ended up working in this specialist arena?
Yeah, of course. So I'm a pelvic health physio. So I started, as most physios do, doing my rotations, trying loads of different types of physio, slowly realised I hated all of them and found pelvic health. So when I say a pelvic health physio, that means lots of things to different people. They might call it a women's health physio, a men's health physio, a pelvic health physio. It's all sort of the same thing. And what I do is I help men and women with their pelvic health. So that might mean helping them with their bladder function, their bowel function, helping them if they have any pelvic pain, any problems with sex and intimacy, or any problems with things like prolapse. So anything that the pelvis does, I'm really interested in. And also the function of the pelvis is a little bit bigger as well in terms of exercise. So people who might have symptoms when they do exercise, I love treating them as well to make sure that we can get them moving in the way they want to without having any symptoms or causing any problems for further down the line.
Oh, wow, that is so succinct. Well done. I mean, okay, so you've kind of given like a broad spectrum. I think when people think of pelvic floor, at least with me before I got pregnant, it was very much thought about like the muscles and the ability, but I guess because of what I do for a living, obviously, to engage and relax your pelvic floor. You don't think about everything else that's happening actually in that whole area and even above it, your whole abdominal wall. All of this is kind of all encompassing of what you do. So can you just go into a bit of detail about who are your typical clients? What are the cases that you often see? Because obviously you don't just do pre and postnatal like myself. What are some of the kind of clients that you see coming to you with?
So I'll start by talking a bit about women. So I actually see women through all stages of life. So I can see women who are teens who are struggling with things like using a tampon or having sex. They're struggling with pain. Then also even sort of into their early 20s, they might have the same thing. In that category, we also have athletes. So things like we know that 80% of trampolinists, if that's the right word, have stress urinary incontinence.
Really?
50% of footballers and basketballers also have stress urinary incontinence.
That
so when we
me.
talk about the pelvic health, everyone loves to picture pregnant women, postnatal women, talking about leaking after having a baby. But actually pelvic health starts much, much, much before that. So I see those young women. I help women through their prenatal, so during pregnancy. Sometimes I help women to try and get pregnant if there's any concerns about sort of any pelvic floor issues or pelvic problems which might be related. And then obviously in their postnatal journey. And then I also see women in the perimenopause. So before that final period, I might help them with symptoms of things like vaginal dryness, pelvic pain, lots of bladder and bowel issues, and also sort of just vaginal discomfort and pelvic pain. Then around the menopause, if those symptoms become more symptomatic. And then I help women the whole way through their life. So the oldest lady I saw was actually 97, and we got her from leaking and terrified to leave the house too dry.
Oh, wow.
So there's absolutely no time when you can or can't have pelvic health physio. So that's sort of women. And then I also treat men. So men tend to have a more overactive pelvic floor in general. But we tend to see men who might be having pelvic pain or problems with getting or maintaining an erection, because the pelvic floor muscles are really important for that. And I also see men after they've had their prostate removed, if they've had surgery, because that can cause lots of problems with erections and with bladder function. They often have a lot of leaking. I also see men who have constipation and all that sort of thing because of those muscles being too overactive. The men I tend to see often are sort of higher level athletes and a lot of cyclists, people who are sort of working at the top of their game and maybe potentially more sort of type A personalities, slightly more stress and a little bit more activity in the pelvic floor. So as you can hear, probably one of the reasons I love working in pelvic health is because it's so varied. And in one day, I can have 12 different people and see completely different parts of life and different experiences. So it's a really novel and exciting place to work.
I love that because, again, I just don't think people think about pelvic floor. Like, you're so right. It's all, I think it's kind of like typecast to pre and postnatal, but it's actually really varied. Just one thing I just have to say out loud. I find the trampolining thing interesting because I would just have thought it's low impact, kind of, but then...
Well, if you think your pelvic floor acts as a trampoline by itself, absorbing the impact of your organs down and bouncing back up. So actually the amount of impact on a trampoline is huge. Wow. And the coordination required is huge.
This is it. So it's happening internally. Like the impact doesn't have to be external.
Well, if you think it's probably a bit of both. The impact of the organs descending onto the pelvic floor and then also everything as you rebound back up. So that's a lot to coordinate. If you think about the amount of injuries that trampolinists get in general,
I mean, they have
to have so much strength and coordination to manage trampolining that the pelvic floor is no different.
How fascinating. And then you kind of touched on it there, but can you give some signs and symptoms that men and women might be experiencing that would indicate to you that potentially this is a pelvic floor issue, both the obvious things like incontinence and maybe less obvious things that they might have not even realised or thought of?
So probably the one that most people think of is the bladder. So either feeling like you have to go for a wee all the time or getting up to go for a wee at night time, feeling like you're really desperate and have to rush, obviously leaking, but lots of people don't leak but don't do things because they don't want to leak. So I'll say to someone, have you ever had any incontinence? No, but I definitely wouldn't get on a trampoline. So actually you are suffering with risk of incontinence. Things like not being able to empty your bladder fully is also a symptom of pelvic floor issues. In terms of the bowel, you might have symptoms of constipation. That's a really big sign that something isn't working well within the pelvic floor. But also things like not being able to control wind, not being able to control the bowel itself, especially if there's loose stool. And also things like birth injuries around the back passage might be related to bowel function. I help with things like prolapse, where the different organs of the pelvis might sit lower, which can cause different symptoms of things like heaviness or dragging or feeling like there's a tampon in when there isn't, or bladder or bowel symptoms. And then there's been some specific things that people might have during pregnancy. So things like pelvic girdle pain, things like a tummy gap, things like struggling to get back to exercise postnatally. And then the other big category of what I treat is pain. So it might be general pelvic discomfort, feeling like that you have a lot worse pain during your cycle. It might be things like having pain with penetration, whether that's a tampon, whether it's a speculum during your smear test, whether it's during intimacy with a partner or by yourself. Anything like that might indicate that actually if you've got pain in the pelvis, it's likely to be to do with your pelvic floor.
Yeah.
But often back and hip pain can be related to pelvic floor issues. And I get a lot of people referred to me because they've seen I hate the phrase sort of normal physio, but the sort of physio you see for your back and hips and those things.
Yeah.
And actually, they weren't getting better, and they see someone like myself and we address the pelvic floor muscles, and that's when we really start to make a difference.
I find it all really interesting, and one thing that, I mean, we're going to get on to, I want to kind of make this podcast accessible to everyone, but obviously, you know, we're talking about specificity here. We're going to get on to and really get into the nitty gritty of pre and postnatal clients. And I don't want to kind of jump the gun, but I'm gonna. How we were talking about earlier, because me and Jo carpooled here. We were talking about earlier when I postnatally started to get such bad cystitis every time after James and I would have sex, and it was awful. Like there were nights of like no sleep, which is really hard when you're already not sleeping because of a baby. And there were days where I had to just really struggle through work, and I was in absolute hell. Family events, and I just presumed, you know, I was, because of breastfeeding, obviously estrogen drops, you're less lubricated. But actually, it was really funny. The one issue that I constantly had, and especially because I wanted a vaginal birth, it was even more of an issue, was that I find it really hard to relax my pelvic floor. I have a very strong pelvic floor. And I told Jo this on the car on the way here about specifically the breastfeeding. And she was like, you do know that that's a real symptom of an overactive pelvic floor. So this is what I would say is really interesting. And to cross over, and there is a question at the end of this, how you talked about bowel issues. And then obviously I think a lot of people would immediately think that they needed to see a dietitian. Do you work with dietitians? Do you have how do you approach it like that?
Yeah, so I think often a pelvic health physio is a really good person to start with.
Yeah.
Because if we address the physical barriers to the function of the pelvis, you're already onto a bit of a winner. But then I also will refer out to loads of different people. So I'll refer to nutritionists or dietitians. I'll refer to urogyne or colorectal teams. I might refer to a pessary fitting team, as that's something that I'm not able to currently do by myself. Yeah. So if someone needs a pessary for a prolapse, we can refer for that. Yeah. I refer a lot to psychosexual counselling or therapy for people who have problems with sex that aren't just physical but are maybe also related to their thoughts and feelings around intimacy. And also obviously referring backwards and forwards between the GP to make sure if there's any particular medications or anything like that someone might need. I also work quite closely with sort of orthopedics. If you've got a back or a hip problem and actually it's not quite as simple as it's just your pelvic floor in inverted commas, it's really good to get a second opinion. And I work really closely with personal trainers because actually it's important that someone has me for the phase that they need me, but actually that I don't then just leave them to go on by themselves. They've actually got some guidance about how to get back to the things that they love doing.
I love that, and my clients will know this. I'm a really big believer in specificity in terms of outreach and help. And the amount, I would say 100%, every time I do a Q&A on Instagram or I take on a new client who asks me about physiotherapy specific things, I'm like, no, I'm not a physio. I can't help you. And I know that it works the other way around, and I just think it's really important for everyone to understand. And we are going to get on to towards the end resources if you can't afford to go and see someone and pay for their time, where you can go if you don't have that kind of disposable income. But it is really important that you find the specific professional in the issue that you're struggling with. And, you know, actually Sophie Medlin, the dietitian, if you go back and listen to our podcast, it's great. She says, I don't deal with diabetics. It's not what I do. I deal with people who are struggling with their bowels. And she's a dietitian, and so is somebody who would give a diet to a diabetic. So really important. And I just wanted to drive that home. This episode of the podcast is sponsored by Symprove, a science-backed water-based supplement containing billions of live and active bacteria that support the gut. The podcast loves to discuss all things gut health, and Symprove are here to support these conversations. I've actually been taking Symprove for years now. It's a staple of my morning routine, helping support my overall gut health and function. It's such an important part of my routine. I even take it on holiday with me to ensure that I'm supporting my gut health, which we all know can do strange things when traveling and eating different foods. Symprove is a non-dairy food supplement proven to deliver live and active bacteria straight to the gut, so it can truly have an impact. 9 out of 10 customers report feeling a beneficial difference after taking Symprove and continue to take it daily. Symprove are offering a 50% discount on your first 3-month subscription. Use code BODCAST50, that's BODCAST50, to order yours today. Visit Symprove.com and use code BODCAST50 for 50% off your first 3-month subscription. Okay, right, Jo, let's swerve. Let's get specific here. At what point, in your opinion, do you think that a pregnant woman should start considering her pelvic floor and her core in the context of her pregnancy, and why?
From the beginning. So the pelvic floor muscles are a sling of muscle that go from your pubic bone all the way to your tailbone and out to both sit bones. And they're really important for controlling the bladder and bowel, controlling sort of around the vagina, so allowing everything to relax, to allow things in and allow the baby out. So actually, if you aren't thinking about your pelvic floor early on, considering all of the changes that are happening during pregnancy, there's elongation of the pelvic floor muscles, there's hormonal changes, there's the increased weight of not only the baby, but the uterus, the amniotic fluid, everything that comes with that. Even the fact that you've got such a higher blood volume, 70% of our weight sits above our pelvic floor. So the idea that we should even be waiting until pregnancy to start considering this is already too late.
Yeah.
If you are sort of, especially if you're an elite athlete, you know, we think about the strength of return to sort of exercise after an injury. Are our ankles strong enough? Are our glutes strong enough? Is our bracing technique good enough for the lift that we want to do? Why are we waiting until there's potentially going to be a dysfunction to start thinking about these things?
Yeah.
So actually, if you know you're trying for a baby, or if you found out that you're pregnant, starting to think about your pelvic floor and your abdominal muscles is really key.
Yeah. And you know what I find interesting, and I want to touch on this before we move on, I think a lot of people who are having an elective C-section or a planned, even if it's not necessarily elected, it ends up being a planned C-section, are like, oh, I don't need to worry about my pelvic floor postnatally because I'm not going to have a vaginal delivery. Touch on that.
So actually, most of the challenges to the pelvic floor happen during pregnancy. So if you imagine your pelvis like a handbag, if your handbag is full, the zip will be really tight. That's like your pelvic floor. And if you take your makeup bag or your wallet out of your handbag, that zip's not going to be tight anymore. So even if we don't do any damage to the zip, if we actually keep the zip intact, there's going to be loads of changes once that baby is out.
Yeah.
So actually, we need to really understand that a lot of the load and changes happen during pregnancy, and that potentially there are different aspects of birth which can cause further challenges to the pelvic floor muscles. But having a cesarean definitely does not act fully preventatively against pelvic floor dysfunction. It does reduce your risk of some things. In particular, it reduces your risk of really severe perineal tears.
Yeah.
Because, of course, if it's coming out the sunroof, you're not going to have a tear into the pelvic floor muscles.
I love it that you even said that term.
Yeah.
It's James's favourite term.
Yeah. But equally, research is really mixed about actually, does a cesarean prevent against prolapse or stress incontinence? Some research says yes, some says no. Yeah. But realistically, neither recovery is easy. This idea that, you know, too posh to push and all this sort of thing, as if it's an easy way out. There is no easy way to get an 8-pound baby out of your body that you've spent 9 months growing.
Yeah.
And I don't say that to make it sound scary, but I think we need to respect all births equally, that, you know, you have to prep. Whether it's a vaginal birth, a cesarean birth, whether you end up having induction, epidurals, episiotomies, tears, scars, whatever it is, there is no easy way out, and appropriate rehab and recovery is so important, especially because you're doing all of that amongst meeting a brand new stranger who can't even stay by itself for 60 seconds that's supposed to be your best friend for life. So you've got to start thinking about it during pregnancy because that is a really hard time to start thinking about it. If you don't think about your pelvic floor until you've had the baby, you're much more at risk of having a tricky time.
There's so much I want to pick up on that. I mean, the amount of press interviews that I've done since having Bodhi, where the journalists will say to me like, well, first of all, you must have found it really hard watching your body change in pregnancy. And look, all credit to people who do find it hard. It's incredibly normal and probably more common. Actually, no, I really loved it. And then also like, God, you must have been gagging to get back and lift weights as soon as you got the 6 week. I was like, first of all, I had a C-section, so I ain't getting a 6 week all clear from anyone. Second of all, and, you know, I really, again, I want to drive this home to any women listening. it's really important that you respect where your body is at that time, and you don't elect to put it in a place and time that it's not in, because all you're going to do is you're going to do more damage, and at some point down the line you're going to have to start again with potentially more red tape around what you can do. Exactly what Jo said. Respect it. What can you do right now? What can't you do right now? Accept that, and then work from there. I want to talk to you about prenatal training, which I know you're going to love the broad spectrum of this topic. Please do give caveats. I know all the words you're going to use to answer this, and I want you to use them. What are the do's and don'ts of prenatal training when pregnant?
So I think it's really important to start by talking about the benefits of exercise during pregnancy. There is so many benefits. Things like making sure that actually you're staying nice and strong, which will help you in the early days of motherhood and during the pregnancy to carry the pregnancy. Really important for mental health, really important for things like controlling maternal and baby weight gain. Yeah. That doesn't mean you gain less, just an appropriate amount for your body and your pregnancy. Mm-hmm. It's also really important for helping to control blood sugars. And it's really good for just generally keeping you strong and fit. So it's definitely something that should be on your radar. Mm-hmm. The recommendation from the World Health Organization is actually no different than for people who aren't pregnant. Yeah. So 150 minutes of moderate intensity exercise in a week, there should be 2 strength-based sessions. Now, that might be going to the gym and lifting weights, or it might be consciously thinking, right, I'm not going to ask my partner to carry the shopping from the car in, I'm going to do it myself. Mm-hmm. So it's really important that we keep exercise up. There's obviously some caveats. So there's some people who have higher risk pregnancies who need to really closely consult with their obstetric team. Yeah. So that's people who have, a relatively severe respiratory or cardiac condition or poorly controlled diabetes. If there's any concerns with the pregnancy, such as recurrent previous miscarriage or problems with an incompetent or weakened cervix, if they're worried the baby's going to come early, or if the placenta position is lower. So in those people, in general, taking advice from social media or even something like this podcast is a hard no. Talk to your obstetrician. Yeah. There's also some exercises which we don't recommend, which are screamingly obvious. Things like skydiving, scuba diving,
kickboxing,
contact sports, anything which might hit the bump or make you fall, obviously. Yeah. Also, we've had some really good research coming out about the fact that, we used to be quite restrictive and have things like the talk test, but we're getting more, which sort of the talk test meant that you shouldn't exercise so hard that you can't talk in a full sentence because there was concerns about oxygenation and blood flow to baby.
Yeah, it's an easy way to gauge rate of perceived exertion. Yeah.
But actually now we're getting more and more research with a really good article this year that's shown that actually it's relatively well tolerated. So the study showed that they did a minute on and a minute off of 90% max heart rate for 10 minutes, and it was really well tolerated, and 30 minutes of moderate intensity up to 75% max heart rate for 30 minutes, and that was well tolerated. So, we shouldn't be scared to exercise, but with sort of high intensity training or even with weight training, it's a big balance between can I do it and should I do it? Yeah. So yes, theoretically you can, but should you? Does your body like it? Mm-hmm. Do you have symptoms? Is there any concerns about pressure? How is your body responding to that? So there's certain things that we need to think about. So like first trimester, really important to think about actually how is your body in general? If you're really nauseous, not sleeping well, not getting good enough nutrition, really, really poor glucose levels, and actually really, really hot and really low blood pressure. Is that a good time to go running? No. Potentially not. But does that mean you can't exercise at all? Definitely not. It just means you just need to do what you can with what your body's telling you at the time. Yeah. There's no research to say that it's dangerous to exercise in the first trimester. It's a good time to keep doing what you were doing before if your body will allow you. Yeah. It's also absolutely fine to do exercises on your back, and you can continue exercises for the abdominal muscles because they haven't started to lengthen and separate. Yeah. In the second trimester, hopefully by that point, the majority of women will be starting to feel a little bit better. They can maybe get a bit better nutrition in without vomiting everything they eat. So that's good. Also, you might have got more accustomed to the changes in your blood pressure. So you're less likely to feel really faint, really hot, really dizzy. Really important to warm up and cool down during this stage because your blood vessels have widened, which means you're much, much more likely to feel fine during a set. And then as soon as you put that weight down or get off the Stairmaster, suddenly feel awful. Yeah. So really making sure you do that warm up and cool down is important. At this point, the abdominal muscles are starting to separate. So we're thinking about things like a tummy gap or diastasis.
Yeah.
So you can't avoid that happening, but we can respect the changes that are happening to your body and actually watching what's happening to your bump whilst you're exercising.
Yes.
And adapting the exercise. So if you notice that your bump goes really pointy or you get a doming or coning in between the tummy muscles, that's a sign that there's an increased pressure in your abdomen. Mm-hmm. And again, we don't necessarily have to panic about it. If you can squish that pressure and it moves back in really easily, you're probably fine to continue if you're feeling all right. Yeah. But if you touch that bit in the middle of your tummy muscles and it feels really hard, it's a sign you're probably working too hard. And we want to step that back slightly.
Yeah.
Second trimester is also a time where the bump might start to get in the way. So for things like lifts and Olympic lifts or anything using the bar, you might want to switch to dumbbells rather than the bar.
Yeah.
You don't have to, but some people find that if they try and change their form to get around the bump, then when the bump's not there, they've lost their form.
Yeah.
So you might want to just switch over, drop your weight slightly. When it comes to third trimester, it's really down to, all of it is, but it's really down to how your body feels. Start thinking about maybe dropping the weight slightly and really adapting the positions that you're in. Mm-hmm. So if you were previously able to do things like things like planks, you're definitely going to be dropping the knees. You're definitely going to be thinking about changing maybe to a wall plank, all those things to change the way you're doing things and maybe starting to reduce impact. And at this point, you really want to start thinking about hip opening. Yeah. So making sure that within your program, you're doing lots of hip opening stretches and dynamic movements to get used to the positions that you need for labour.
Yeah.
We really want to stay strong because actually during labour, you're probably going to be in a slightly strange position for a prolonged period of time. Yeah. Loads of women birth squatting. And if you can't hold a wall squat for 30 seconds, but you want to birth your baby in squatting, you're going to have a problem because you're going to be there for more than 30 seconds.
And you won't know that till you get there. You won't know what position is comfortable until you are actively in childbirth, which didn't happen to me, unfortunately.
So I think the main take homes for training during pregnancy is make sure that you're listening to your body, respecting the changes that are happening in your abdominals, noticing any symptoms that you've got. So if you have leaking, heaviness, pain at the front or the back of the pelvis, or you're feeling something just doesn't quite feel right in your body, you definitely need to be seeing someone about it and then getting them to help you adapt and modify your exercise. Yeah. It's never just stop unless there's a concern about safety. Yeah. It will always be, let's change the weight that you're using or the type of weight you're using. So maybe we're going to go from a kettlebell to a dumbbell. Maybe we're going to go from a bar to a dumbbell, something like that. Yeah. But definitely we don't want to stop because stopping exercise is more risky for the baby and the mum than actually continuing in a modified way.
I love that you say that because I think there's so, look, my audience probably know training in pregnancy, and as long as we're staying away from progressive overload or say you've never gone for a run in your life, being like, I'm going to do a marathon, or you've never squatted a weight in your life, being like, I'm going to get under the Olympic bar today. Obviously, probably not a good idea. Progressive overload is a no. Maintenance is a big fat yes. And I think my audience know this, but, let's just presume they don't. The myth that now you're pregnant, you need to be wrapped in cotton wool and you have to lie down. Obviously, as we said, if you're high risk, yes, likely. If not in the beginning, certainly at some point, yes. But everybody else, to stop exercise is going to actually impede the health of you, your pregnant body, your unborn baby, and your potentially childbirth and recovery thereafter. So it is important to find a way. Now that, as Jo said, I just want to again give some context here. I couldn't train at all for the first 2.5 months. And I was so sick. I was so unbelievably poorly. And I had really bad migraines as well, which I'd never heard of happening, but it happened to me. And it wasn't until my second trimester that I actually could really resume everything that I'd done. And I felt really happy about that. Then I got iron deficiency anemia and I started fainting all over the shop. So obviously it took a hit again towards the end of my second trimester, beginning of my third. And my third trimester was great. And then I got so uncomfortable. Even doing a deadlift felt funny with my bump, which it really shouldn't when I think of the mechanics of it and I think of the trajectory of the bar. My form started to go and it was because I was nervous about it and I had to cut deadlifts, which I wasn't expecting. And it really is so much about you and how you feel in your own body, how you feel in a lift. There were things that should have been fine on paper, but in practice when I did them felt wrong, like dumbbell pullovers, even on an incline. just felt very, very wrong. And I had to cut them. So really listen to your body. And I urge everybody to be reactive and responsive to what your body is telling you, and don't feel like you're just kind of, I don't know, pussying out of something. If your body says no, just listen to it, and find an alternative. Okay, let's say that you want what a lot of women want, which is this kind of like, I guess, archetypal water birth, natural delivery. Is that what you would say the majority of your clients want?
I think most people want to breathe their baby out either in or out of a pool with nobody doing anything to them.
That's me.
In as short a time as possible.
This is me, right? And I think, actually, let's touch on this first, because I think I really want to touch on this. We need to touch on this. Even my antenatal lady and my hypnobirth lady.
Wow.
There you go. No, great for me. Because I was hell-bent on that kind of birth, the water birth with no pain medication, and they really made a point to say in between a lot of sentences, like, of course, you don't know what's going to happen. You might end up having to have a C-section. But aside from that, the whole conversation was very laced in, but, don't let people interfere with you. Don't be told, if you feel fine that you need a C-section when you feel like the baby's coming and will come on its own, don't worry. And this one worried me and worries me in hindsight now that I know the statistics behind this. Don't worry if your baby's 2 weeks overdue. No one needs to push you into having an induction. That one in particular, wow. But I think that had a lot to do with when I wasn't induced because I was a week overdue, and they were like, okay, it's time now. Plus my waters broke as well, which really meant it was time. I was really upset when I was induced, but I stiff up a lip, and I was like, you know what? As long as it doesn't result in a C-section, it's fine. Inevitably, when it ended up resulting in a C-section, I was heartbroken. I cried as soon as she told me. My obstetrician, Shazia, who's incredible, and she knows what she's doing, and I don't. Never had a baby before, have no medical experience. Was heartbroken, cried the whole way through into the operating theatre, cried the whole way through my C-section until I was told the reason why my baby was not coming out vaginally, and that was because she was really tangled up in the umbilical cord, which wasn't a problem until it came to my vaginal non-delivery. And then all of a sudden it was like I had this reason why, I had this context, and I was so happy then that there was a reason. And then like a few seconds later, Shazia showed me my baby, and I cried with joy, and I get so emotional talking about it just because it's the most bizarre feeling I've never had before, and I don't know if I'll ever have again. A first baby, I don't know. And everything slotted into place, and I was joyous, and I've stayed that way since. I was very lucky I didn't get any baby blues. Now, Jo, I want you to talk a little bit about the preparation that women... Well, actually, you know what? No, let's stay on this topic. What do you think about everything I've just said, and what's your experience of it, and what's your take on it?
I think preparing for all sorts of types of birth can be really empowering, because if you only prepare and dream of type A birth, then as soon as it's not that, it's disappointing. Mm-hmm. Whereas if you know what the different options are, including different options for pain relief, different types of perineal trauma that you might have. So the idea that they might need to do an episiotomy, which is a cut into the pelvic floor muscles to help birth your baby. If you don't know what forceps are, if you don't know what a ventouse is, then when they say to you, actually, we're quite worried about your baby and we want to do an episiotomy and then maybe ventouse, and if that doesn't work, forceps, it's terrifying. Yeah. Whereas if you've got a bit of an idea that you at least know what it is, the pros and the cons, then when someone does suggest that that might be needed, it means that you're prepared mentally for it. It doesn't necessarily mean that it's what you want, but it might be that you change your mind and it's what you want in that situation to help get you and your baby safely together. I also think that lots of people plan for all types of vaginal birth, but have an absolute anti-cesarean plan.
Me.
And the thing is, that's fine if everything goes to plan. Yeah. But you can't plan birth.
No.
And you can't control birth. And I think knowing what the early days of recovery should look like for both is really important, because lots of people plan for a vaginal birth, end up with a cesarean birth, and then are on the ward the next day thinking, well, what on earth do I do now? Can I even pick up the baby? Can I cuddle my baby? Yeah. My baby's kicking my scar. Is that okay? What am I supposed to do with my dressing? What's going to happen to the scar? Should I be using silicone? Shouldn't I? What type? Yeah. It's an absolute minefield. Whereas if you'd sort of thought about it and done a tiny bit of reading beforehand, that initial panic will be less.
Yeah.
Because you know that actually there's lots and lots of options, and that actually you're just dealing with a scar in a different place.
Yeah.
So yes, it is major abdominal surgery, and yes, it goes through 8 layers. So it's a big surgery. It's not something that we should be, rolling our eyes at. It's something really significant. But that doesn't mean that we should then just not think about it.
Yeah.
We should prepare for all births equally.
Yeah. Okay. Childbirth preparation. You're kind of talking about it now. Epi-No?
So I love the Epi-No.
Me too.
But we've got to be really careful that the Epi-No is quite expensive. Let's talk about perineal massage first.
Okay, go on.
So perineal massage is something that you can do from 34 weeks, where you use your thumb to help stretch the perineum. It's not particularly enjoyable, and it's something that quite a few people find a bit tricky to do and get the hang of, and often people's partners might help them. It's got loads of research behind it for reducing serious tears, reducing less serious tears, reducing pushing time, reducing rate of instrumental delivery and cesarean delivery.
It's got good data there.
It's really, really worth doing.
Yeah.
There's even some research that it shows that your baby does all the things it's supposed to do when it's born quicker, like get pink, cry, wriggle around a little bit. All of those things happen quicker. There's data for it. So we really, really should be recommending that. And that's something that you can do for about 10 minutes, and you do it a couple of times a week from 34 weeks. And there's loads of research behind that. And I really strongly encourage anybody who's planning a vaginal birth to be doing that.
Right.
You have to do it quite regularly for it to work, because we're actually doing 2 things. One is we are physically stretching the tissues, but the other thing we're doing is we're teaching our nervous system that really intense kind of burny feeling is okay.
Yeah.
Because if you've never felt that feeling before, and then you go into labour and you get to crowning, your pelvic floor muscles will feel that and they will become tense because it's scary.
Yeah.
Whereas if you know that feeling and you think, oh yeah, that's that really intense burny feeling that I wasn't a huge fan of,
Yeah.
that means that my baby's nearly here.
Yeah.
Then it's much easier to slow down crowning, allow the pelvic floor to relax and stretch, and to birth your baby with less perineal trauma.
Yeah.
So actually it's partly about your body learning that alongside the stretching. The Epi-No is a device that you can put inside the vagina and inflate. What that does is it's very similar in its physiology to perineal massage, in that it stretches the pelvic floor and perineal tissues and helps you learn about the sensation of that. The reason why I really like it for those that can afford it is it's got like different measurements on it. So for people who are competitive, you do not need to get to 10 centimetres. Your body will get you there during labour. But more if let's say you first put it in. You had
to talk me into this. I was like, I'm stuck on 9. You were like, that's really good.
Really good. Because actually it's all about that retraining of the feeling. And often people first put the Epi-No in, only get to 2 centimetres, panic, call me and say, how on earth am I going to birth a baby?
Yeah.
And I say, well, stick with it.
Yeah.
You start at 37 weeks, and actually you'll notice that a lot of it is mind over matter.
Oh, yeah.
That your body actually learns. And if you think about what we were just talking about, if you can have that process before you have your baby, it means that when you get to 2 centimetres of crowning, you don't go, oh my God,
fuck.
what is that?
Yeah. Well, so my sister-in-law said when my nephew, she had the perfect birth, like, oh my God. And this is like, I was like, this is the birth I will have it. It's not. But she said when Kit was actually crowning, she was like, oh, this feels like the Epi-No.
Exactly.
And she stayed calm because of it. Yeah.
The other thing is that actually, if you've got quite a big bump and quite short arms, and aren't feeling particularly comfortable with quite big boobs, actually reaching your own vagina is quite challenging.
Like a T-Rex.
Literally. So some people want their partner to do it, and some people shudder at the thought of their partner doing it.
Oh, James and I did it together. Yeah, it was so funny.
But the Epi-No means it's something that you can do by yourself, because you pop it in and then you can control it. The other thing that's really good about it is that if it gets too much, it's got a little valve. You just deflate it and you think, oh, that was quite intense. Let's have another go.
Yeah.
It's really important that you don't push into pain with the Epi-No.
No.
So some people, if they really, really inflate it too quickly, too fast, thinking that the goal is 10 centimetres, are sort of missing the benefits, because the whole point is that you get to a point where you think, oh, that's quite intense. Let me think about my birth affirmations. Let me think about my hypnobirthing. Let's think about relaxing the pelvic floor. Let's think about, can I cope and work out during birth, what am I going to do? That is the benefit of the Epi-No, rather than I got to 10 centimetres and cried for 10 minutes. That is not the goal.
And now it burns when I pee.
Yeah.
No, it's so interesting. I very naturally and organically found myself going into breath work when I was doing it. And then it wasn't till I met Jo. It was so funny when Jo first assessed me. She was like, okay, so you have a really strong pelvic floor. And I was like, yes. Like, obviously my third trimester. She was like, no. First of all, you need to know when to relax it. It's important. And second of all, babe, you want to vaginal delivery, like, and I was like, oh, right, okay. And you do find yourself getting really competitive. It's really weird. I actually think it's a survival mechanism, because that childbirth looming, like, I needed that, and I needed to feel like it was a challenge and I was going to win it, or I honestly think I would have freaked out.
I think, just to interject slightly there, we weren't concerned about how strong your pelvic floor is. We love a strong pelvic floor, but we also like a pelvic floor that is flexible and is coordinated to the task at hand.
Yeah.
So if you are just lying down, you shouldn't have a pelvic floor that's on.
No.
So it's more about making sure that your pelvic floor is really strong at the right time for as long as it needs to be. And that's the really important thing, that we also during birth need the muscles to relax at the right time to allow your baby to be born. So it's so, so important that you have that awareness of your pelvic floor. You know when it's on, you know when it's off, so that actually during birth you can consciously think, oh, my body didn't quite like that contraction. My pelvic floor's really gripping on. Let's relax my jaw, relax my tummy, relax my pelvic floor. Let's get this baby out.
What's that little rhyme you do about jaw, the floor?
Tight jaw, tight floor.
Yeah, there you go.
Yeah. So there's quite a lot.
My jaw's always tight.
Yeah, there's an embryological connection, i.e. when you're an embryo, they come from the same bit of the embryo. And that's why a tight jaw often means a tight pelvic floor. And lots of people during birth, you'll hear midwives a lot say, relax your jaw, and it will make a big difference.
Funny. Well, I mean, they would know. You know what I'm realizing? I actually think maybe we should keep this podcast to the prenatal, like, childbirth preparation, and maybe do recovery on another episode, because I just think I'm not even halfway through my questions, and I know that so many people listening will be like, okay, I already had my baby 2 weeks ago, like, what do I do now? And I actually think we should do a part 2 if you're happy to do that.
Absolutely.
Yeah.
I think the really important thing about postnatal, pelvic health, prenatal, everything we're talking about, is that it's just so hard to get information. And if you listen to lots of podcasts, we tend to do like a really quick skim dive of like, this is the pelvic floor, do some Kegels, hope for the best, and that's it. But actually the postnatal part of recovery is so important. If we think about timelines for women, so we know that after the menopause, it is harder to gain muscle mass, and it is really hard to gain bone density. And it's actually hard to even slow down losing it, of both. Same with cardiovascular health, etc. So if let's say as most women who have babies probably have between 1 to 3 children, maybe in the space of about 6 years, sort of ish. And each baby, if we think about it as crudely as 9 months of pregnancy, 9 months of postnatal training, you've got 3 sets of 18 months in this critical window where you want to build muscle mass, you want to gain bone density before it comes 10 times harder. If you've done that for over a 6-year period, and actually women are having babies later, that means that you head straight from pregnancy, postnatal, perimenopause, menopause.
Wow, I didn't ever think of it like this.
Exercise is vital. And so many women who've just had a baby, or maybe 2 years postnatal, come to see me and they say, oh, well, I didn't really have any problems after my birth, but now it's really bothersome. And I say, okay, well, what's happening with your cycles? And they say, well, I can't be perimenopausal. I'm only 2 years postnatal. But actually, if you've had your baby's late, your body clock hasn't changed.
It doesn't work like that. And that's such a good point. I didn't even think of it like that. And also, this is a period of your life, just while we're on it, where resistance training is pivotal. You're talking about osteoporosis, sarcopenia, all these preventative of all of these really horrible ramifications of basically just being a woman, inescapable being a woman. And I just want to just quickly throw that in there. Like, it's really important. And also, by the way, postmenopausal women, protein increases, I would say, in like 2 grams per 1 kg of lean mass, at least, for you to be able to really work your hardest to hold on to that muscle.
Okay, you've worked hard to gain it. You want it to stay there.
You want it to stay. And the thing is, like, I don't want to fearmonger anyone. I lost 5 kg of muscle when I was pregnant, and I I'm looking at my body now and I'm like, I'm gaining it back pretty quickly. And obviously you'd expect to because of central nervous system. But you know, you can get it back. But yeah, let's do everything we can to try hold on to it, 'cause especially as women, it's not that easy. I would say 50% of my clients are peri or postmenopausal.
Well, as we're living older, that's half of our lifespan.
Exactly. And a significant amount of my friends are actually like early menopausal, which is... Yeah, I mean, it's interesting. So maybe this will be one of a couple of podcasts that we do with Jo. Let's come back to pregnancy. Just for everybody listening, can you give short, succinct meaning of these words?
Of course.
Okay, ready? You already know everything.
I feel like it's quick fire.
Yeah, it's quick fire. Okay, vaginal delivery.
So when the baby comes out through the vagina.
Okay, episiotomy.
So an episiotomy is a cut that the obstetrician will do that doesn't go straight down towards the back passage. It goes slightly out to the side. And they'll do it, and it goes through the pelvic floor muscles and the perineal body, which is like a fibrous part of the perineum. They'll do it for a few different reasons. They'll often do it before an instrumental birth to reduce your risk of significant tears, or they'll do it if there's concerns that the baby isn't actually able to get out.
Yeah.
So they'll do it if they need to speed up birth. It's a type of perineal trauma, and it goes through lots of different layers, and it's not something necessary to worry about. They're relatively common, but similar to a cesarean scar, it's really important that with any perineal scar, that muscle in between the vagina and the back passage, any scars there, we need to really respect and work on after birth.
Yeah, scar tissue is a big thing, and I think we'll do this in another episode.
Yeah, sorry, I didn't do quick fire on that one.
No, I know, but no, I love it. This is really important. I'm loving this so much. I actually forgot about loads of stuff you're talking about. I'm like, oh my God, how funny. That's my hippocampus shrinking in pregnancy. Okay, perineal tear.
Perineal tear. So there's different types of tears. So you can have a grade 1 tear, which means that it's just the skin, and it just doesn't affect the pelvic floor muscles, and it goes into the perineum, so the skin between the vagina and the back passage. That can also be called a labial graze. A second degree tear affects the skin and also the pelvic floor muscles. So it affects the muscles in between the vagina and the back passage. A third and fourth degree tear affects the anal sphincter muscles to different levels. They're less common, and everybody is terrified of them, understandably. Even sort of talking about it sounds terrifying.
Yeah.
And they definitely do need more recovery and rehab afterwards, but that doesn't necessarily mean that you are going to have bad outcomes. There are lots of women who've had third and fourth degree tears who are back running marathons, lifting heavy. It just might take you a little bit longer to make sure that we get those sphincter muscles working really well again alongside the pelvic floor. So for anybody who's listening who's had a third or fourth degree tear and is panicking, don't panic. It's going to be okay. Just make sure you get a good team around you, and make sure you optimize your bowel habits. Yeah. And if you see a pelvic health physio, they'll be able to help you get that scar up and running, no problems, and get you back to all your goals.
I love that. And one thing Jo's really big on, and I'm really just so here for it, is like, don't panic. You're never at not at the end of the road. We'll figure it out. Go see a professional. They might refer you. It might be a joint team effort, but we can get you where you want to go. Okay, cesarean section.
So a cesarean section is when they make a small cut just below your bikini line, and that they go through 8 different layers to get to your baby in the uterus, and they deliver the baby through that abdominal wound, and then they stitch you all the way back up. Okay. And it'll happen in a theatre, but you can normally have your partner with you if everything's going okay. Yeah. And for most women, if it's not an emergency or if it's a lower level emergency, you're awake and they can drop the curtains, you can see your baby, and lots of women have skin to skin straight away. Yeah. So actually, although it's something lots of people are very fearful of, learning more about it in your birth prep is vital so that you can actually picture what it looks like.
Yeah. What it feels like, that's the interesting thing.
Yeah.
That's always very interesting. Forceps.
So forceps is a metal device. Lots of people talk about it like 2 spoons, which is a bit graphic, but actually probably in an audio format, the best way of describing it. And what they do is they put those through the vaginal opening onto the baby's head, so they can help pull the baby out if they're worried that either mum or baby is in distress and they need to get the baby out quickly.
Ventouse.
So ventouse is similar in that it's a suction cup that they pop onto the baby's head. So if they're worried that the baby's not arriving quickly enough, they'll put this little suction cup through the vaginal opening onto the baby's head and help pull the baby out as you try and push the baby out at the same time. And both forceps and ventouse deliveries are called instrumental deliveries. It's also a certain type of ventouse is called a kiwi. So if you ever get told you've had a kiwi birth, that's also a ventouse. It's just a brand.
Oh, okay. Fine. It's like, wait, what is it? A New Zealand
sounds
obstetrician?
Like, it sounds like you've gone to Australia.
Yeah. Different types of pain relief.
So you've got lots of different types of pain relief. Things like you can start with just using heat and using water, building up to things like gas and air. Then you can take things like dihydrocodeine. Then you can build up to sort of more stronger pain relief, such as like a mobile epidural. So that means that it's sort of you have reduced sensation and you shouldn't have pain from below the waist downwards. And you should still be able to walk around. It's called a mobile epidural, all the way up to a full spinal block, which is what you have during a cesarean. Or if they do an instrumental birth in theatre where they're worried that they might have to flip to a cesarean quickly if they're worried about something. Depending on your hospital, they might have other things that you can use, things like TENS, although it sounds ridiculous, things like aromatherapy and things which boost oxytocin can be really useful. Things like a rebozo, which is like a scarf that people use to help support the bump in different birthing positions, can help modify pain. But one of the biggest things that you can do is actually work out before you have your baby, where can your partner stand to provide counter pressure?
Oh, yeah.
So where on your pelvis feels good, feels bad, not really sure. It's not a great time when you're, 8 centimetres dilated, furious with everyone, hadn't had anything to eat and about to transition. Now's not a great time to work out what feels good. Practice in your birth prep to make sure that you know what does your body like.
I am so here for this, and I'm really annoyed that we have to go, but I feel like we've done a lot about postnatal. Well, we've done a lot about pelvic floor health, which is really important. We've really touched on the prenatal, the training, the childbirth prep, what to expect, different things that might happen. I think we're going to have to do another episode, and I think we're going to have to do a whole episode on postnatal. Potentially a third, a whole episode on the menopause, which, as we are learning, thanks to Davina McCall, has a huge audience, and rightly so. And everybody should be talking about it and aware of what's going on with their bodies as they age, including men. But for now, I think we're just going to call it here. Next time we have Jo on, we will delve deep into postnatal, again, including recovery, scar massage, training, do's and don'ts, everything, but just on the other side of pregnancy. Jo, thank you for coming in. Can you just tell everybody where they can find you if they like what you have to say and want to have a chat with you?
Of course. So I'm on Instagram at Jo Gipson Physio, and then I've also got a website which is jogipsonphysiotherapy.com.
It's a very nice website.
Yeah, thank you. And anybody who's got any concerns, worries, not sure if pelvic health physio is for them, the fact you're thinking about it means it probably is. So book in for a complimentary call, have a chat, see what do you need. I might even be able to signpost you to someone locally to you, or it might be that I'm hoping it'll obviously be something that I can help with as well. So definitely the take home is, if you've got symptoms, definitely get yourself with a pelvic health physio. We don't mind if you've shaved your legs, if you've,
I can
not
attest,
had a shower.
She did not mind.
If you're covered in baby sick, we don't mind. The most important thing is that you turn up. And if you have no symptoms but have big goals, it's a great idea to get checked as well. So any questions, any worries, reach out, get in touch.
That hit home. No symptoms, big goals. That was me. But actually I did have symptoms because I was freaking out. I was like, again, not about my body in the moment of pregnancy, but after the recovery, I was like, hang on. What the hell is my body going to look like, feel like? What am I meant to do here? You are so tired, and then you have a baby. It's like you need to be told what to do. This is the beauty of going to a coach or a specialist. Like, just tell me what to do and I'll do it. Jo, absolutely adore you, and let's do this again as soon as possible and give a postnatal rundown. Guys, thank you so much for listening to another episode of the Bodcast. If you like this episode or any episode, please post about it on social media. Please please subscribe, share. I promise you it really, really helps. And we want to keep the podcast going, and you guys have done such a good job since 2018 in doing that. So please keep on keeping on. I hope you all have a lovely week, and we'll see you in a few days.